Well, welcome to our panel on our police peer support programs today. My name is Dr. Jacqueline Drew, and I'm going to be the moderator for the panel. We have 4 speakers that you'll hear from, speaking around that central theme of how to create, implement, and also evaluate police peer support programs. John Petrollo will talk about the POPPER program. Sherry Martin will discuss Power and Peers program. Then we'll hear from Dr. Tom Coughlin, who'll provide a clinician's perspective of peer support. And lastly, I'll speak about the evidence for peer support programs in policing. So given the short time frame, I won't read everyone's extensive bios, but you can access information about us and also our contact details on the app. So I'd like to introduce our first speaker, John Petrollo. John Petrollo is the current director of POPPER, the police organisation providing peer assistance. He joined the New York City Police Department in 1984. POPPER opened in 1996 in response to the shocking number of NYPD police suicides in 94 and 95. I'll hand over to John now for his presentation. Thanks, John.
Okay, thank you, and thank you for the opportunity to share our program with everybody. Our program is a little different than your department peer organizations. It's outside of the department, but it is embraced by the New York City Police Department. Our history is we started back in '96 because we had a high rate of suicide. 26 cops killed themselves in a 2-year period. And then the problem with it was the city council got involved, the police department, the mayor's office. We have services in place, but why aren't they calling? And then finally they realized, let's let a group of cops get together working outside of the department and let them have some flexibility in getting new officers help. And then hence that's how we started in 1996. It's a unique partnership with the New York City Police Department, not found anywhere else in the country. A lot of times I get calls from other departments asking about trying to get one started. And the problem with that is egos and politics get in the way. That has to be removed from what we're doing. It's non-departmental. It's embraced by the department. We service both retired and active police officers from NYPD, and it's an alternative to department services. It's not in any way to replace department services, not in any way to replace mental health professionals or EAPs. This is to be a segue and complement the services. We're able to get that population that's not very friendly to mental health or has a problem with going to mental health. So we get them, segue them into it, get them comfortable with it. And that's part of the base of the program, the foundation. We have other programs. We've expanded since we were just a suicide intervention back in the day. We now do traumatic responses to traumatic incidents. We do CISM debriefings with officers after involved in any type of discharge of weapons or firefight. We do resiliency support program. We have our new SAFER program, which is out there. It's a 1-day suicide awareness. We give it to our police officers. We give it to their family members. It helps them identify signs that somebody is going down that route and how to deal with it and not to just dismiss it. We have officer support groups, military returnee groups, and we also do outreaches. It's important to make sure you can reach out to your population, the departments, on a regular basis because they forget services available after a while. So we speak to recruit classes, promotional classes, supervisors when they have their meetings, borough-based trainings. We'll have, new recruits. We'll have a couple of thousand at a time. We have 35,000 officers. The way we select our peers and what makes it so doable is that the application is put in by the peer who wants to do this. This isn't somebody that's getting the job assignment. This is somebody that wants to do it. They're going to get interviewed, 3 different sets of interviews, first by peers, then by the director and a psychologist, and then by another set of peers and mental health professionals. We do a panel review after that. Importance of that is we want to make sure that they're good from the peer end, that they make good peers, that they're approachable, and the clinicians in the room in the interview are making sure that they're psychologically prepared for what they're going to be doing. They get trained. They get an 8-day training. It's 2 days continued every year after that. They're taught to do screenings to make referrals to mental health professional. We never take on the role as counselor. That's not what we want to do. That's above our scale. We want to get them into a mental health professional. They're also able to check for assessment on suicide ideation, which is one of the questions they're all asked or told that they must ask. And it's just supportive techniques. It's to break down the barriers of reaching out for help. Nothing better than one cop reaching out to another, to a population that's resistant to mental health. Team structure is the president, the director. We have two clinical people. One is our case manager, and the other one is the liaison to Papa from the department. They don't interfere. They don't ask for records, but they do want to have some insurance that the people we see and we're putting them back to work, that they are up to the standards of the department afterwards. So they have a department liaison that reports nothing back to them, but just make sure that we're giving them the proper documentation that this person's ready to go back. We didn't get into the operation of it. There's somebody who oversees that. We have a training coordinator, and then we have the individual teams. We have 10 different teams. They have a coordinator, assistant coordinator, and a schedule. And then there's all the 200 plus peers that we have that man the helpline on a 24-hour basis. The importance of it being volunteer. Well, we have to break down the wall with the cops. So why are you doing this? What's in it for you? You're getting days off. No, they're doing it on their own time. They're doing it because they care. And once the cops get that message, we have a much easier time getting them into help. They need to know that the person's doing it is doing it for the right reason. That's one of the most important things of our peer group. Support teams versus mental health. I want to remove the verse because there is no verse. It's working in conjunction with each other. It's the most important component of this, is making sure we have a good mental health team together, because again, we don't want to take this on as a weekly call. We want to get them the help they need right away. We've had documented over 200 cops that were suicidal that called and are alive today over the past 24 years. This stuff works, and I've become passionate about it. Hence why I'm doing what I do today. Some complications in law enforcement, the critical incidences, PTSD, institutional stress, and most of what we get now with the stress is job stress. Cops are under an enormous amount of stress now, more than I've ever seen in my career, and I don't think there's a cop alive today that could say that it lasted this long between the pandemic and the protests and anti-police. These cops are stressed. The anxiety level is through the roof. We're seeing an increase in critical cases because of everything going on. This is more important today than it's ever been. Again, all this leading to alcohol abuse, aggression, suicide. Reasons cops don't reach out for assistance, which many should probably already know. The fear of job problems, of something going in their folder, losing their weapon, the stigma by their fellow cops. Look at him, he's weak, he's reaching out for help, and distrust of the department's psychological services. As much as the departments have it and it's in place, it's a matter of perception. If the cop perceives that to be a problem, well, we have to meet them where they're at. We need to give them other options, be it EAP, be it peer department peers, or outside peers. Again, the peer line is available 24 hours a day. We make sure it's manned. We have two different ones, one for retirees and one for active. We also have a third helpline set up for the department to call us whenever there's shooting or police involved suicide. The important part of it is it's voluntary clients. You have to want to call to get services. We don't take referrals from supervisors. That's where department EAPs come in place. We don't just give them a referral over the phone. Some groups just say, here, go see the doc. And we go out, we meet with them, we sit, we make sure we meet with them and get a good feel for them and give them the right referral. They're trained to be able to do the referrals. If it's crisis, if it's urgent, they know we have hospitals lined up. We have clinicians we could reach 24 hours a day. Some of the reasons we get our calls in, stress and anxiety are 30%. And again, a lot of it is job stress now. What's going on today has really, that number is going to be higher when we take the stats for 2020, 2021. And all of that leads to their marital problems. So that could fit into the job stress, creating marital problems, the traumatic stress from what they're going to see, alcohol problems that follow, the depression. So those are the areas where our calls come in from. We have what's called the blue light sick. This is where it gets the egos and the politics has to be put aside. Sometimes we have to put cops out sick. It's a small percentage of what we do, but we have to take them under our umbrella. That's where the departments can't get the information. They have to be willing to say it's more important to help the cop right now than to worry about what's going on. Egos, politics, it'll ruin it every time. This department, NYPD, has been phenomenal since this started in '96 under Police Commissioner Bratton. It's continued through every commissioner, and it works, and they respect the boundaries as we respect their boundaries on what they can do for us. But we're able to get them put out sick. We're able to work with them for 6 months, get them put back to full duty. And again, it's a very small percentage that don't. Some of our outreaches post COVID, we were able to outreach to 20,000 of our police officers. We then took that and broke it down into 2,200 officers, went into small group debriefings, dealing with topics such as services available, suicide awareness, taking better care of themselves, and that small group breakout, which consisted of talking about their traumatic experiences that they may have had on the job and getting them into the habit of starting to open up and talking under the right conditions. We also do family outreaches with suicide awareness, how to better their relationship, self-care, meditation. All of that has been put out there for our cops now. We're also doing a family weekend. As soon as COVID clears, we can get our facilities back. We're going to take them away overnight with them and a loved one or a significant other, and we're going to give them some good skills on self-care. Or if the cops who don't want to bring their significant other or don't have a significant other, we're going to do one just for the cops. And they're going to get an array of suicide awareness. They're going to get how to better relationships, everything above. And we also go out and do deployments. The debriefings are so important. This is just one where we were in Boston during their bombing. We've been out to Houston and Baltimore and New Orleans during their some situations they've had. The peer breakdown of them going out to other departments has worked phenomenal. It's allowed the cops the opportunity to speak to another cop from an outside department. It really works well. And we all should be in agreement that, you know, you're healthier cop on the left here, happier, more productive, better decision making. The list goes on. And then we have the unhealthy cop who's going to be angry, less productive, make poor decisions. So it's a win-win for everybody, be it the community, be it the department, be it the police officer and the police officer's family, that we keep them healthy. And just giving them the options to have a choice of where they can go to get help is one of the most important things we could do. If they choose the department, they choose the department. If they choose us, if they choose an EAP, that's all great as long as we give them the option. So with that said, I will then turn it over to the next speaker, and we'll be around at the end to answer any questions you may have.
Awesome. Thanks, John. That's me. I'm next. So I'm going to, while I work on sharing my screen, I just want to say, you know, a lot of the points that John makes, you're going to hear echoed throughout the presentation. We have done research within our organization and found many of the same things that John just said. You see me, I was nodding the entire time he was speaking. So I'm just going to take a moment just briefly to introduce the FOP and our history. We note that we've seen a significant increase in our membership over the past few years, you know, and that's for a number of reasons. You know, officers are having a tough time with a lot of things. So, you know, I must say that 356,000 number, it continues to increase, and we've probably gained 5,000 members in the past year alone. So until the past few decades, the FOP primarily focused on advocacy for members of law enforcement through labor and legislative action. And it took some 85 years for the profession to accept that critical incidents had an effect on officers and our working conditions. And then around 2001, the National FOP established a critical incident committee to work on assisting members of departments that had suffered critical incidents. And then in 2013, we began to recognize that there was much more to wellness than a reaction to critical incidents. The committee was transformed into the Officer Wellness Committee. Then in late 2019, the FOP took the position that it was a necessity that officer wellness become one of the pillars of our organization, much as labor and legislative advocacy had always been. So I'm proud to say that we now have a division of wellness services. We had an opportunity in 2018 that since guided our work in the Division of Wellness Services. We were approached by NBC there in New York because they were interested in learning about critical stress suffered by members of law enforcement. So together with them, we designed a survey to gauge the issue. And in today's session, we're going to focus on a few of the things that we learned. Among our respondents, we observed a sharp lack of use of employer-provided employee assistance programs, just as John said. There's, a mistrust in our profession sometimes of agency provided services. And when they were used, they were deemed only partially helpful. So, we have to ask, could this be that there was a lack of trust in the resource to begin with? So by contrast, peer counseling at the time that we did the survey was not as readily available to many because, larger agencies like NYPD already have things like this set up, but there's many small agencies out there that even still may not yet have peer support. But it was identified most by those who have used it as being the most helpful of services offered to them. However, even some who use that service are reluctant to use it. There are some agencies where the peer may still fear that through gossip or rumor mill or whatever, they'll be, found out that they were struggling with something. So we saw that the FOP has a unique ability to fill a gap in services here. And so based on this data and looking at existing peer support programs, great programs like PAPA, we recognize that there was no standardized program of peer support available nationwide, given that we have members in all 50 states, as well as the District of Columbia and Puerto Rico. We wanted to create a standard of practice in this area that we could, make available to people everywhere. We're currently working with the United States Department of Justice to build such a standard. And as we developed this program, we wanted to research how Power and Peers, as it will be called, could best support our personnel. So we went straight to the source. We know that peer support and programs like it have historically focused on critical incidents. However, we recognize, just as John said, that stress affects members of law enforcement, and it comes from many sources, with organizational stress, interagency politics, and the like being rated as a higher source of stress than the actual duties of being a police officer. What goes on inside the four walls is oftentimes much more stressful. We know also that life as a first responder entails unique living circumstances. So we suspect other stresses come into play as well. We knew we needed to gauge when peer support would be most sought by our members. And here's what our research is showing us. The data I'll share with you in the next few minutes comes from our ongoing survey within the profession, which we're going to use to inform curriculum development and Power and Peers. It's significant to note that while the majority of respondents indicate that they would still most utilize peer support post-critical incident, they would also like support in other areas as well. Unfortunately, we do still have a small percentage of folks who are still not comfortable with using peer support. Likely we attribute that back to what I said a minute ago about smaller agencies and there still being a fear of their secret getting out. But we're working on a plan that I'll talk about how to deal with that as well. We see here again that while most support is desired with stresses related to the job, nearly half of our respondents would also like support with family issues and other issues that are not related to the job. So we know we have to provide training to our peer mentors that will enable them to support others in these areas as well. With that data in mind, we're currently developing the Power and Peers curriculum. Using our research, we're going to draw upon the best portions of current curriculums in providing peer support post-critical incident. And then we'll utilize concepts from the field of positive psychology to build modules geared toward everyday support and helping the supported officer realize and utilize their personal strengths. Finally, we're going to include tools that will enable us to evaluate the effectiveness of the curriculum with pre and post measures and tracking of utilization of the program. I mentioned a minute ago that there may still be some issues with being reluctant to use peer support, especially in smaller agencies. So what we're going to do as we take this training, Power and Peers, around the country, it's going to naturally create a network of trained peer supporters across the country, so that a peer on the East Coast can call a trained peer on the West Coast, and there isn't going to be that fear of having the coworker go back to the workplace the next day and maybe slip and let something out. This training is going to provide components that officers said they would like support in, and then the more folks that we reach, the more we're going to be able to help people. So with this network, we're going to be able to reach folks maybe in some places that wouldn't have sought peer support otherwise. We are forming this curriculum with the expertise of some subject matter experts, one of which is Dr. Coughlin, who's on this panel today. And we have one of our subject matter experts is a positive psychology expert as well. And so we are excited about what's coming. This you see mentioned here, parts of the larger FOP wellness program. We have a state wellness liaison cadre, so we have a leader in each state lodge in the FOP that's going to take the lead on wellness efforts. Our Officer Wellness Summit is a training event. Same with our Wellness Professionals Forum. It's a training event specifically for clinicians that work with law enforcement population. And then our Approved Provider Bulletin is a nationwide directory of culturally competent services for law enforcement. That's going to be available online when it's published in the near future, so that officers all over the country will be able to utilize that resource to find mental health services or wellness services in their area. And then finally, something that I want to mention is we know how important it is to gather research from our members, the officers, the boots on the ground doing the job, and to try to gauge what they're experiencing out there every day. And so in the FOP, we have a number of committees that work on everything related to the livelihood and working conditions of law enforcement, whether it be, body armor, body cameras, working with their communities, their pensions. And so we're going to talk with those leaders of those committees and start to develop a survey every 2 years that's going to gauge what law enforcement is going through out there, which we hope is going to then further inform the profession and lead us to development of greater services for law enforcement and the public. And so with that, I'll throw my contact information right up there, and I'm going to stop sharing and hand it over to Dr. Coughlin.
Thank you very much, Sherry. I appreciate it. Let me share my screen for everybody. Okay. Thank you very much, Sherry. Welcome, everybody. Thank you for joining us today in this discussion on peer support. So I just want to highlight just a couple of my background points, just that to kind of drive home my experience in regard to peer support. As John mentioned earlier, there's one person in the police department that has access to or involvement in the actual people receiving confidential mental health treatment through the PAPA program. And for 4 years, from 2014 to 2018, I held that position as the department liaison to the PAPA program. I'm also continue to work as an affiliated clinician with the PAPA program. So I receive referrals from mental health services from members of the NYPD who reach out for confidential mental health services. And then I also do EAP work with the Drug Enforcement Administration. And so I have access to experiences in many different places, from the department side, looking in at a peer support team, being an affiliated clinician with a peer support team, and also doing EAP services. And so I draw upon all of those experiences in what I'm going to go over. Just a brief review of the research, talk about some keys to success in peer support work from a clinical standpoint, the purpose of peer support programming, what that should look like, selection and training, and where mental health professionals fit in regard to selection and training. Guidelines, what guidelines are out there and should be relied on in regard to designing a peer support team, implementing it, some legal considerations to think about, and then just ending with a brief mention of fitness for duty things to consider also. And so, as Sherry mentioned, we have some really good data, some really good research from the FOP NBC partnership study. And what it told us, basically, with the down and dirty, the research told us is that cops prefer peer support as their primary intervention method, right? They prefer it over internal department services. They prefer it over EAP services as well. And so it's a question of why, right? So we have that data. Data is always helpful, but if that's the issue, if cops do prefer peer support, well, why, and how can we leverage that answer as to why to help us get even more buy-in from both the agency level as well as the rank and file level. So we know that there's a reluctance to utilize EAP programs. So as I say, I do some EAP work, but it's interesting because the EAP that I work with is a law enforcement specific EAP. So in the same way that, as Sherry mentioned, with Power and Peers and with the provider approved bulletin, all of those clinicians will be vetted to have law enforcement expertise. the EAP that I work with is also a law enforcement specific EAP, right? And it really makes a huge difference, right? So it's one thing for a cop to think that they're just calling out to just sort of the same municipal EAP that everybody in the municipality or everybody in the state answers to. It's another thing for a cop to know that the clinicians on the other end of the EAP are police psychologists, vetted law enforcement, police specific, culturally competent psychologists. And that really does make a big difference. So there's so many different variations of these programming out there. It's important to ask ourselves, why are some more effective than others? And how can we leverage that reason? What are those keys to success, right? So we know that from the research that there is a preference for peer support, and we have to think about what are the keys to success in regard to peer support, and how can we draw upon those for even greater success. So in my experience clinically, working with cops that have either reached out to peer support for help or working internally in the department as liaison to the peer support program, the keys to success that I've noticed is number one, absolutely confidentiality, right? There can be no greater emphasis on confidentiality, right? You can't overemphasize how important confidentiality is for true, effective, successful peer support work. I've had cops come forward for help and express to me sort of in this sense, I'm really not concerned with whether or not I get better. I'm really concerned that nobody knows that I reached out for help, right? That's really sad. That's actually really heartbreaking. And I've heard that expressed to me by more than one cops, not just cops, more than one law enforcement officers, because I see people at the federal level as well and multiple police agencies as well. And I've had that expressed to me. I'm just not concerned whether or not I get better at all. I'm concerned that nobody finds out that I was here, right? So confidentiality is absolutely key. Relatability, right? Peer support work has automatic buy-in of credibility and relatability. They know that the person that they're speaking to is a cop. They don't have to explain law enforcement to them. They don't have to explain policing to them or the things that come along. They're already occupationally aware and culturally competent. It's already automatically brought in that relatability and that credibility. It reduces the coercion, right? A lot of times cops are told that they need to get into treatment or told that they have to reach out to someone. Anytime you have coerced treatment, you just have low engagement in treatment, right? Coerced treatment is ineffective treatment, right? So I have a lot of cops that sit on my couch because they've received some ultimatum from somewhere in their life that they need to be in my office sitting on my couch. And the level of engagement from those clients is just much, much lower than the clients who reached out voluntarily from help. Peer support gives that avenue where a cop can willingly, purposefully reach out for help to another peer, someone who understands them, reduces that coercive element of treatment. It reduces the fear of being suspected of malingering, right? And, without going into, deeper, dirtier details, I once worked for a boss who, in a clinical capacity, a boss whose mantra was, all cops lie. They all lie, right? And this was a boss, a director in a wellness capacity, right? Like immediately they were suspecting every cop who came to the front door and about why are they in the office and why are they here and what is this all about? Peer support removes that entire concern that I'm going to be suspected of not being true when I come forward, that my motivations for coming forward for help are going to be suspect, because you're working with a peer. There's relatability and credibility there. It reduces the adversarial relationship, right? You're working with a peer. You're not working with somebody who's perceived to be an adversary, right? If we think about cops, for the most part, the first time a cop interacts with a mental health professional, it's through a pre-employment evaluation. The second time is typically through a fitness for duty evaluation. And in both times, those are adversarial relationships. Peer support reduces that, and even as a bridge to clinical services, reduces that adversarial piece. And it reduces treatment resistance by normalizing the experience of reaching out for help. So peer support, the purpose should be to augment a comprehensive wellness system. It should not be to be in any way in competition with an overall wellness system. It should be to provide emotional and tangible support through either professional crises or through personal crises. It should be short-term peer contact for support, providing day-to-day emotional support, as well as response to critical incidents. But then it should also be as a bridge to clinical services. So yes, there is that component when you're just interacting with a peer, speaking to a peer, but there's also that piece where you should be providing a bridge to clinical services. Peer support selection, mental health professionals should certainly have a role in peer support selection. As John mentioned earlier, there is a place during the peer support officer process in which a mental health professional should be involved in the interviewing process. I certainly agree with that. And there should be overall clinical insight at all times throughout the peer process. As far as guidelines, there is no uniform standard for any kind of guidelines for peer support. There's no governable enforceable code for it. There's kind of a lot of disparate ways of designing peer support programs out there, different ways of going about it. While there is certifying bodies and organizations, there is no standardized guideline. And they're really, hopefully in the field, we're moving toward a place where there will eventually be some kind of a standardized procedure and standardized guideline for peer support. We need organizations like the FOP to kind of be the tip of the spear, as Sherry's office is, and kind of reaching forward, going towards, aspiring towards some kind of a standardized guideline or standardized code and procedure. The IACP has some available guidelines. It's available up on their website, and they cover a lot of all the various facets of peer support programming, how to select your peers, how to deal with administration, confidentiality, and training issues. And they recommend clinical oversight, right? Professional psychological consultation, ongoing 24/7 psychological consultation. You definitely want mental health professionals to be available at all times to consult with your peers if they should have a question about a case or whether or not a case needs to be referred into clinical services. You want there to be that 24/7 consultation availability for peers that might need to know, this seems to be outside of my scope, this seems to be on the scope of peer support, we might need a bridge to clinical services here, and bring in that mental health professional to consult in regard to that. It's a question of whether or not peer support team should ever intervene in the disciplinary process or be involved with somebody who's already disciplinarily involved in the department, and should that rule them out of use of services, right? These are all things to consider when you're thinking about putting together and designing and implementing a peer support program, or should you just simply serve as doing disciplinary stress triage? So you do an outreach for anybody going through the disciplinary process to see how they're holding up throughout the process, what their stress level is like. If you're going to do this kind of work, if you're going to do peer support work, you should know the laws specific to peer support work in your state. Right. And this is where the FOP can really be of a tremendous help for all of their legal advisory people. States vary from state to state about how much protections they offer, or they offer any protections at all to peer support officers being compelled to have to testify in court. Right. And you want to know what your statutes are. Right. So, for example, in Georgia, there are privileged communications between law enforcement officers and their PSOs, except, and then the statute goes on to list a very, very lengthy list of exceptions to that privilege, right? And so you really want to know in your state whether or not as a PSO you can be compelled to testify in court as to what you might interact with a peer in regard to. And if you're going to design and oversee a peer support program, you definitely want to be up to date in regard to those legal codes. So yes, there should be ongoing clinical supervision for your peer support officers. There should also be mental health aftercare and support for your peer support officers, right? They're dealing with all the stress out there. It's a lot of vicarious trauma involved with being a peer support officer. And you should have aftercare and mental health outreach to your PSOs to make sure that they're engaging in good self-care and that they're taking care of themselves as well. And finally, just a mention of some fitness for duty considerations. Just bear in mind, if you're going to do peer support work, eventually at some point, a fitness for duty issue is going to come up, right? And so you should understand, someone comes forward for peer support, a clinical outreach is made, and then the clinician that they go see determines this person can't safely and effectively perform the essential functions of their job. We need to take their guns from them. You need to really understand how that's going to work and what that's going to look like. Because once that cop says, wait a second, I reached out to peer support and they sent me to a clinician and I lost my guns, and they badmouth the whole program for that, you just really have to think proactively about how those things will be handled, so that you know how to deal with fitness for duty issues should they come up. And with that said, I am going to surrender the screen and hand it off to Dr. Drew.
Thanks so much, Tom. And I think that's a good segue into now talking about how we evaluate when you've reviewed a number of the guidelines. So let's see. All right. So to begin the presentation, I'd just like to acknowledge my co-author who you've already heard from, Sherry Martin, who's the National Director of Wellness Services. And the research that I'm going to talk about today about designing and implementing and evaluating peer support programs is collaborative work that we have been doing together. So this is one part of a program of collaboration that Sherry and I have been involved in for the last year or so. We've published a number of studies, some of using the survey data that Sherry talked about, looking at stigma and help seeking in policing. We've recently published some work around critical issues for police leaders in the post-COVID environment. And we also have another paper under review looking at stress and wellbeing of police and their families during COVID. So the research that I'll talk about today, though, and really focus on is the research we've been doing around police peer support programs and undertaking a systematic review of the literature about what is the evidence to support its use, given the fact that, over a number of years now, we really have seen an explosion of peer support programs in the police environment. So we had a number of key questions that we wanted to address through our literature review. Firstly is, a key question around, are peer support programs an appropriate intervention to assist in protecting specifically the psychological health and wellbeing of police? We were also interested in understanding what role peer support programs play in really a larger suite of hopefully what agencies are doing in the psychological health and support service space more generally, and also how does it link into other initiatives like stigma reduction programs, and how do they support or differ in achieving outcomes that we're looking for? We were also really interested in trying to determine what are the elements that make up best practice peer support programs for police, and what are the specific outcomes that we should expect from actually a peer support program that may differ from those other programs. So ultimately, are they effective and why was driving our research. So I'm just going to talk about a couple of papers that came before our paper. One 13 years ago in 2008 was the first review of police peer support programs. And then just recently in October last year, we saw another paper come out that tried to capture what the research was saying around both peer support as well as crisis-focused psychological interventions. So to begin with, I'll talk about that study that happened a number of years ago in 2008. This review at that time looked at police workplace assistance and peer support programs, but it didn't try to capture or evaluate peer support program effectiveness from the perspective of officers receiving peer services. And my guess is the reason they didn't do that because that there wasn't any articles that actually assessed that. And even with that caveat, they were only able to find 3 published studies on workplace peer assistance and support for police. And there was 1 non-empirical report that focused more generally on a review of the literature on stress and peer support in the policing environment. So I guess what we were hoping when we saw this study, and we found a study that had happened 13 years ago, that our systematic review would be able to find many more studies than 3 to guide those questions that I nominated before. So they found in that review at the time that there were significant limitations, obviously, in the empirical research on peer support programs for police. And as I said, that was back in 2008. So we were hoping to see many more studies when we did our review. They identified that there were significant gaps in knowledge about peer intervention models and programs. And they noticed that even in that time, all those years ago, there was seemingly a wave of programs being widely approved across police agencies. But that endorsement by police agencies seemed really to be largely based more on observation and intuition and conjecture opposed to solid empirical evidence. It felt right to do, so we did it. They noted that evaluation was definitely needed, and particularly, as I mentioned earlier, from the perspective of officers receiving the peer support service themselves. So we fast forward to October 2020, when this research came out, which also undertook a type of systematic review around peer support programs, but their focus was on the effectiveness of organisational peer support as well as crisis-focused psychological interventions. So their review specifically was looking at peer support that was offered in respect to post-traumatic incidents or events, whereas the research that I'll talk about in a minute that Sherry and I did, we had a much broader frame. It was just peer support generally in policing. It didn't have to be tied to post-traumatic events. So they looked at the literature between 2008 and 2019, and they included a number of groups, not just police, public safety personnel more generally, of course, which police fell under, frontline health personnel, and other potentially psychologically traumatic event exposed workers. That's a mouthful. Their review was a little bit better in terms of the numbers that were able to be identified. So they identified 14 eligible studies, but of course that was across all those groups. When we looked just at police and what studies they were able to find, they found 4 studies that were specific to or included police. So we increased by 1 study. And of course, both of these studies had different frames of literature reviews and different criteria for selection. But we didn't see a huge jump just looking at psychological interventions based on traumatic events and peer support, given the fact they only found 4 studies. So their key findings were interesting. They did find some positive results regarding peer support programs in policing, and they noted one by Carlton that was conducted in Canada, who did report short-lived, small, but importantly statistically significant improvements in stigma following the Road to Mental Readiness training program, which many of you probably have heard about. The more concerning aspect, I guess, was they didn't find any statistically significant improvements in mental health based on that program. The other 2 studies, and they had 2 different types of outcome measures. One looked at the outcome of sick leave, the other looked at the outcome of suicide, reported some favourable results, but really it was limited by the quality of the research that was undertaken, and the strength of evidence wasn't that strong. There was one study that found evidence for improved mental health scores with fewer post-traumatic stress indicator symptoms associated with specifically trauma risk management training and the TRIM program you may have heard of in the UK. There's a low to moderate evidence to support peer support programs, was their conclusion, for use with public sector or public safety personnel. But the impact of programs, again, and this echoed the research that happened in 2008, the impact of programs on mental health and absenteeism is rarely available to review in the empirical literature that's widely available. They indicated, and this is their general conclusion at the end, that the available evidence to make conclusive decisions regarding the use of such programs actually based on an evidence base is impossible right now. So that leads us to the research that we conducted. So we conducted a systematic review using the PRISMA guidelines, and we had the following eligibility criteria. So we went back as far as we could in terms of the research. We didn't have any time frame as such. It was from the beginning of time, I guess, up to February 2020. It could be in any geographic location. We really tried to look across particularly US, UK, Canada, Australia, New Zealand. The only criteria was it had to be published in the English language, the research. We only looked at police and law enforcement because that's what we wanted to focus on. And we also were looking for research that actually was evaluating a formal peer support program, not simply support of peers in the police environment. It had to be related to a formal program. The methodological design that met our eligibility criteria is they had to have some pre and post measure of the training. So we knew that there was actual real change from pre to post engagement in a peer support program or engagement with peers in that formal sense. Or at least there had to be some post measure of training effectiveness, even if there wasn't that pre-measure. And of course, the studies had to have an outcome measure that was focused on studying the effectiveness or the outcomes of engaging with peers that were formally trained in a peer support program within the police environment. The outcomes we were interested in were mental health knowledge, mental health and wellbeing changes, including symptomology, stigma reduction, as well as barriers to help seeking. We excluded a number of studies that were simply descriptive evaluations that didn't have systematic or primary data collection from program participants, and program participants included both peer supporters or those receiving peer support, case studies, and if they didn't have an evaluation of an outcome variable that we were interested in, and our interest in outcome variables was quite wide, so that didn't knock too many out actually. So what did we find? A little bit more positive than 13 years ago, thank goodness. But we didn't only find less than 15 documents, and we're still sorting through those last few in the preparation of our paper. But our conclusion is there's less than 15 documents, including articles, theses, and reports that met the inclusion criteria and were available for us to analyse. This tells us that the number of evaluations that are publicly available and shared widely for use, so other agencies can learn off each other, is disproportionately small compared to the large increases in the uptake of police peer support programs we've seen in many countries. We also concluded that if evaluations are being conducted, they simply aren't being published because we couldn't find them. Therefore, this creates a number of issues. One, we don't know the rigour of methodology of designs of evaluations. So when agencies say that their peer support programs work, we haven't got a criteria on which to judge what evidence they're using to say that. There's little information about how the programs are being designed. And when they are described, often papers will look at descriptions of peer support programs, but there won't be any evaluation data. So we can't start unpacking what the elements are of the peer support program that actually works. And really, I mean, this is one of the things that I guess we need to address, and I'll talk about later, is there's really a lack of sharing, specifically with evidence about what works. So it's really difficult to know how we can start designing and implementing what we would call best practice programs that really are maximally effective in police agencies and are the best use of resources when we don't really have a solid evidence base to work off. So returning to the key questions that drove our review, are peer support programs an appropriate intervention that can assist in protecting the psychological health and wellbeing of police? Maybe, probably, but we need more evidence to definitively say so. We know that there's some positive evidence, as we've heard about from the last three speakers, but we don't have a systematic evidence base on which to definitively say yes. What role do peer support programs play? There's no research really to provide a clear indication of how peer support fits within the overall program of mental health and wellness for police. We don't know how it should be used in conjunction with other types of interventions. What are the elements? Well, we know what's included in many peer support programs, but which elements are most effective? Which are the ones that constitute best practice? We don't really know that yet. And what outcomes should we expect from peer support programs? Well, peer support programs all have aims and objectives, but do they achieve them? And as I've said, we have little evidence or little information to draw those conclusions right now. So ultimately, our question was, are they effective and why? There is still much to be done in understanding the role, design, delivery, and implementation of peer support programs within our agencies. And I guess this research is a call to action to all the groups involved to undertake good evaluation research, but most importantly, to also share it. We can't rely on everyone is doing it, so it must work. We know the folly of doing this in policing already, and we should learn from history. So evidence has taught us that sometimes things are different to sometimes things are different to what we once believed. So for instance, rapid response policing, we know that differential responses to calls for service are the way to go and the use of resources is much better. We moved away from many years of using random patrols. We know that focus patrols vastly improve the use of resources and effectiveness of crime control. And just more recently, critical incident stress debriefing, which agencies undertook in droves for a number of years until we found evidence that psychological debriefing is not particularly effective and it can in fact be harmful. So we need to learn from these lessons. So should we abandon peer support programs? No, but it's time to make sure that we're doing the best we can to provide support for mental health and wellbeing of our officers. And that's through research, evaluation, and striving for best practice. So to give you a quote that I think really sums up our research, although good intentions are behind our social interventions, good intentions do not equal positive outcomes. We really have an ethical duty, all of us, to our public and to our officers, to be up to date on empirical research concerning our interventions and make sure we're doing the right thing. Thank you very much. I'm just going to stop sharing. Okay. We have finished, I think, with 1 minute to spare. So good job, everyone. I would just check if there's any questions. I don't think there is.
Yeah, I don't see any.
No. Okay, well, thank you, everyone. That concludes our panel today. I want to thank my fellow panelists for their contribution, and it was a privilege to present with the three of you. Please reach out to us, any of the attendees, if you want more information. Our contact details are available through the conference website, and we're all on LinkedIn if you'd like to reach out to us through that. Thank you so much and have a great day.
Thank you all.
Thank
Enjoy the
you.
conference.
Thanks.
Bye.
Thank you.